Good day, everyone. Welcome to Accriva Diagnostics webinar this morning, or this afternoon, depending on where in the world you are, which is featuring our guest presenter, Dr. Dániel Aradi. Dr. Aradi will discuss a recent study which was published in the European Heart Journal this past April. This was a study which was included in the collaborative review of 17 other studies that were published prior to January 2015. And from that review, the data were analyzed collectively to better identify the prognostic relevance of platelet reactivity and how this may help in stratifying risk after percutaneous coronary intervention. Next slide. Okay. Just to let you know, there are two of us participating on this call who are from Accriva. We will be assisting purely as moderators and technical support to Dr. Aradi. First, there's Adam Weinstein, who's based in the UK and represents us from a focus on the marketing perspective in those markets outside the United States. So, Adam, do you want to say hello? You'll be hearing more from him later.
Hello.
And myself, Tanya Leese. I'm the global product manager for the VerifyNow system. This was one of the systems that was used in these studies during the collaborative review that will be discussed today. While this is sponsored by Accriva, today's webinar focuses on clinical education. So Dr. Aradi will be speaking to the study from his own clinical insights on platelet reactivity testing. Due to the large number of attendees, the phone lines will remain muted throughout the session, but there will be time for question and answer at the end of the call. So if you do have any questions during the presentation, feel free to type them into the questions section on your webinar control panel. You might take a look at that now to see where that is. And we'll be able to see those questions, and when we get to the Q&A segment, Adam will be moderating at the end to take some of those questions and let Dr. Aradi speak to them. So you're already seeing that we have guest presenter today. Let me introduce you now to Dr. Dániel Aradi, who is an interventional cardiologist and an assistant professor. He heads the thrombosis research at Heart Center of Balatonfüred and the Heart and Vascular Center at Semmelweis University in Budapest, Hungary. He has participated in and authored a number of studies related to antiplatelet therapy testing, including several meta-analyses similar to this collaborative review. So now please join us in welcoming Dr. Aradi today as we turn the webinar over to him to share his review of the prognostic value of platelet reactivity testing after PCI. Dr. Aradi?
Dear Tanya, thank you very much for your kind introduction, and I welcome everyone of you online, and I hope you will have a good session. And the title of the session today is Prognostic Value of Platelet Reactivity Testing after PCI. And I'd like to inform you about a new project that we have completed with the largest number of studies, the largest number of patients so far on the prognostic value of platelet function testing on bleeding and thrombosis. So these are my potential conflicts of interest. In the following approximately 35-40 minutes, I would like to focus my talk in three major topics. First, I would like to discuss with you the drug response on P2Y12 inhibitors and the reasons why I believe platelet function testing is important. Second, we would like to focus on the prognostic value of platelet function testing and especially share with you our results of this pooled analysis including over 20,000 patients. And finally, I would like to also go into details about how can we integrate these results into our clinical practice. Is the current role of platelet function testing to treat better our patients after PCI? So first, let's talk about drug response on P2Y12 inhibitors. I think you all know that platelets play a key role in the progression of acute coronary syndrome and myocardial infarction in patients after PCI. And if we look back into the past decades, we know that if we give platelet inhibitors, they are effective in reducing thrombotic events in patients with acute coronary syndrome and after PCI. So by giving more and more potent antiplatelet agents, we could successfully reduce the risk of ischemic events. However, we should also notice that during these successful reductions, there have been always a price to pay for a universal treatment of antiplatelet agents, which is bleeding. And while in the early days with the less potent agents, bleeding in absolute risk was not an issue, now we are reaching a level when bleeding is approaching the thrombotic event risk. If we go into the most popular P2Y12 inhibitor, clopidogrel was really effective compared to placebo to reduce the risk of thrombotic events. However, during the past 10 years, we learned that platelet reactivity after clopidogrel is really variable. So if you have your patients and you treat them with the same fixed dose of clopidogrel, you will see that some of your patients will have very reactive platelets. They are at the similar range of placebo. They have very reactive platelets. We call them high platelet reactivity. However, other patients on the same dose of clopidogrel will have very strong platelet inhibition, and they will have very potent platelet inhibition, which we may call low platelet reactivity on the same drug. So whatever platelet function testing device you are using, you see this huge interpatient variability with clopidogrel, which may have clinical consequences. And there are also evidence from other sort of studies that these values that you have in your platelet function testing environment is not some artifact, because we have clear evidence from pharmacodynamic and pharmacokinetic studies that the interpatient variability in clopidogrel is largely because of the large variability in the active metabolite levels. So in this figure, you see that the blue triangles are the clopidogrel patients, and there is a huge variation in the level of active metabolites, which relate directly to the level of platelet inhibition. So we have now more potent platelet inhibitors like prasugrel, which only differs from clopidogrel, that prasugrel is generating more active metabolites, which act similarly as clopidogrel on the P2Y12 receptor, but this higher level of active metabolites results in higher level of platelet inhibition. So these pharmacokinetic results are strongly in correlation and in support the pharmacodynamic results that we have and that we see in platelet function testing. And in the past years, we learned that one of the most important reasons for these interpatient variations in case of clopidogrel is single nucleotide polymorphisms in the liver enzymes that catalyze the activation of clopidogrel. Because if you take a clopidogrel tablet, 85 to 90% of the tablet directly goes to an inactive metabolite, and only a very small portion goes to your liver, which undergoes this activation process. So in your liver, if you have so-called loss of function enzymes, you will have very low concentration of active metabolite. However, if you have good enzymes, you will have high levels of active metabolite. But the problem is that you don't know, if you don't test, what kind of enzymes and what kind of active metabolite levels do you have. So I believe all these results support that maybe the one-size-for-all approach that we are using from years in case of antiplatelet treatment is not appropriate to our patients. Because not only the patients are really different, but also the genetic background makes it also very complicated to determine what dose and what agent is the best for your patient. And in fact, due to this hidden genetic determinant, it may be the case that your slim lady will have high platelet reactivity if she has loss of functional alleles. In turn, an obese diabetic patient can have low platelet reactivity if she has extensive metabolizer status. So all these data support that we may need to measure and monitor the dose effect to know how clopidogrel is acting in our patients. And I told you before that we have now newer agents such as prasugrel, which are more potent and have a more rapid onset of action. And we had phase 3 trials showing that in general prasugrel reduces death and minor stroke compared to clopidogrel. But if we separate our patients into non-carriers of loss of functional enzymes who have good response to clopidogrel and carriers of these loss of functional alleles who have poor response to clopidogrel, we see that if the clopidogrel is working in their patient, they can achieve the similar level of thrombotic risk as prasugrel treated patients. So these data suggest that if you select your patients who respond well on clopidogrel, you will have similar good outcomes as those who have very strong platelet inhibition with the new agent prasugrel. And newer agents such as prasugrel and ticagrelor are in general more potent and has a more rapid onset of action. But if you see this study, it's clearly demonstrating that although prasugrel mean platelet inhibition is stronger than clopidogrel, there is still a variability in case of prasugrel, which we see in our patients. So although prasugrel is more effective than clopidogrel, there is still a variability between patients how they respond to the drug. And also, this is data from our group from Hungary who we participated in the Plato study that investigated ticagrelor compared to clopidogrel in acute coronary syndrome patients. And what we saw in our platelet function sub-study of our Plato cohort is that although ticagrelor is more effective than clopidogrel and has a reduced level of variability, it's still there is some sort of variability with ticagrelor, and this variability is shifted to the lower platelet reactivity levels, which may suggest that with the newer agents, platelet function testing may be still relevant. However, it may be more important to detect patients who have excessive platelet inhibition and low platelet reactivity, who may be exposed to bleeding events. So, dear colleagues, my conclusions from the first slide is that platelet reactivity on clopidogrel is highly variable and unpredictable. This is not a laboratory artifact. This is a proof, and mainly this is due to the fact that there is really a heterogeneity how we generate active metabolites from clopidogrel. And since there are genetic factors influencing this variability, these are hidden from clinicians. So if you just take into considerations the clinical risk factors of your patient, you won't know how the drug is acting in your patient. So testing for both high and low platelet reactivity is relevant in case of clopidogrel because there is a huge variability in action. The newer agents, prasugrel and ticagrelor, provide more rapid and more potent platelet inhibition in general, but to a lower extent, variability is still present with the newer agents. And this this response with prazolam and ticagrelor is shifted towards the low platelet reactivity zone. So, although testing with the new P2Y12 inhibitors may be less relevant, there is a potential need to select patients who have excessive platelet inhibition and might be exposed to bleeding with prazolam and ticagrelor. So let's turn now to the second part and let's explore what we have found out about the prognostic value of platelet function testing. Before we have completed our own analysis, there have been some studies showing that platelet reactivity results after PCI are associated with thrombotic and bleeding complications. And the largest body of evidence is coming from the RCTS registry, which is a multinational, multicentral prospective registry designed to detect the prognostic value of platelet function testing with the VerifyNow device. So based on this large registry involving over 8,000 patients and having a follow-up of 1 and 2 years, we had the strongest body of evidence supporting that those patients who have platelet reactivity with the VerifyNow above 208 PRU, they have a significantly higher risk of stent thrombosis. At 1 year, approximately 2.5-fold higher risk for stent thrombosis compared to those who have PRU value lower than 208. However, if you turn the tide and check bleeding, those patients who had high platelet reactivity had in turn a lower risk for bleeding. They had approximately 70% reduction of bleeding. So what we see here from this registry is completely the same that we have learned from clinical studies with antiplatelet agents. If we intensify platelet inhibition and reduce platelet reactivity, we can reduce stent thrombosis, but the expense is a higher risk for bleeding. However, all these data suggested a potential relevance of a therapeutic window for P2Y12 receptor inhibitors, which is very similar that we know and what we practice in case of vitamin K antagonist, so that if we have less effective P2Y12 inhibition, we have a higher risk for ischemic event. However, if we have more potent P2Y12 inhibition, we will have a higher risk for bleeding events. So there may be a potential sweet spot, a potential therapeutic window within which the ischemic and bleeding risk is the lowest. So this is only a concept of this therapeutic window. This therapeutic window has not been validated in a large number of patients. However, in a consensus paper back to 2013, we have postulated the presence of this therapeutic window, and we have recommended potential cutoff values for 3 standardized platelet function assay and the coagulation assay to potentially target this therapeutic window. However, there have been several criticisms against this proposal because many people said that these cutoffs were not validated independently in a large sample size of patients, and we have never ever validated this so-called optimal zone of platelet reactivity. And most of the prior studies only looked at either HPR or LPR in separate studies, but these things were not evaluated in the same cohorts. So all these data mandated us to initiate a project, a collaborative project to determine the role of platelet reactivity after PCI. And based on our prior postulation about a potential role of a therapeutic window, we have classified platelet reactivity now in three ranges. So we have defined low platelet reactivity zone, an optimal platelet reactivity zone, which is in fact the therapeutic window that we would like to see to reduce bleeding and thrombosis, and the high platelet reactivity zone. And we assessed these three levels of platelet reactivity by three standardized platelet function assays with the VerifyNow P2Y12, the multiplate ADP test, and the WASP P2Y12 kit. All these levels of platelet reactivity were defined by predefined standardized cutoff values that I will shortly discuss with you. And we included both stable angina and acute coronary syndrome patients in this analysis. So this was really an all-comer large patient population reflecting our everyday clinical practice. We had our endpoints of clinical interest as definitive probable stent thrombosis, major bleeding, and all-cause mortality at the longest follow-up available. So what we did is that we looked for studies published before January 2015 reporting an association between platelet reactivity, stent thrombosis, and major bleeding. I told you before that we wanted to use standardized platelet reactivity cutoffs, and therefore we only accepted standardized platelet function assays, and therefore we have excluded light transmission aggregometry that we felt is not a good candidate for such standardized cutoffs. However, with the three standardized devices, VerifyNow, Multiplate, and VASP, we searched for the best available evidence to define the optimal cutoff for low platelet reactivity and high platelet reactivity. So we found three studies which were considered best available evidence for each of the devices to predefine these optimal cutoff values. In case of the VerifyNow, it was the Aradi study published by Greg Stone in 2013, and their data suggested a cutoff value of 208 PRU for high platelet reactivity and 95 PRU for low platelet reactivity. In case of Multiplate, we have selected the study of deroxibine from 2010 and defined high platelet reactivity as a multiplate value above 46 and low platelet reactivity below 19 units. In case of WASP, we have selected the study of Bonello from 2012 with a cutoff for HPR above 50 platelet reactivity and for the low platelet reactivity 60 in PRI. Which is really important, and I want you to understand the unique feature of this analysis is that we not simply put together all these studies as a usual meta-analysis. Based on the exploratory trials, we ask all the other authors to reanalyze their data, their previously published data, with these cutoffs that we have selected, and then we have pulled all the data together with these uniform cutoff values. So all the results that you will see will precisely show what these cutoffs mean to these patients. So just some slides again about the VerifyNow cutoff. You have seen that from the RCTS registry over 8,000 patients, it has been clearly shown that high platelet reactivity, which is PRU above 208, is a significant determinant of a high risk for stent thrombosis. So So this is the reason why we selected 208 PRU. In case of bleeding, there have been a publication of Greg Stone and N.J. Curtain that if they divide their population into quintiles, the risk of bleeding is really increased in the lowest quintile. And the cutoff for this lowest quintile was 95 PRU. So this is the reason why we have selected 95 PRU to define low platelet reactivity, a potential threshold for bleeding. So finally, we have selected 17 studies of 20,839 patients. Many of these studies are well known to you in case of VerifyNow, such as the Gravitas study, from which we have only included the control arm who received standard dose of clopidogrel. But as I told you, RCTS and several other previously published studies that have used a different cutoff, but they have reanalyzed their data with the new cutoff that we have proposed. So some basic facts about these data. Basically, in the pooled analysis, we had 64% of patients coming from the VerifyNow studies. So the VerifyNow group is the largest group in all the analyses. 19% of the patients were coming from multiplate and 17 from West assay. If we pool all the results, high platelet reactivity was 41% in all the patients, and low platelet reactivity was present in 20% of the population. It's very important to highlight that all the data that we have reflects a clopidogrel-treated population with 97% of patients receiving clopidogrel and only 3% of the patients receiving prasugrel. So far, we haven't found any studies with platelet reactivity on ticagrelor showing an association with clinical outcomes. As I told you, this was really a mixed population of ACS and non-ACS patients. Median ACS rate was 53%, and we had a median length of follow-up of 8.5 months, with a median DES rate in the studies of 64%. So basically, I think this is a good representation of our current routine practice. All the results in detail are available in the European Heart Journal publication, and please allow me to share with you some of the most important messages of this analysis. So basically, regarding the risk of stent thrombosis, when we separated patients into 3 categories, it turned out that those patients who have high platelet reactivity, they had a 2.7-fold higher risk for stent thrombosis. P-value is extremely significant, confirming that the statistical power of our analysis is extremely robust. This may not be so interesting to you that compared to an optimal level of platelet reactivity, patients who have insufficient platelet inhibition and have high platelet reactivity, they have higher risk for stent thrombosis. What may be new and what may be really interesting is that if you further inhibit your platelets, if you go to the low platelet reactivity zone, there is no additional benefit in reducing stent thrombosis, which means that if you would like to reduce stent thrombosis, it may be enough to reduce it into the optimal platelet reactivity range defined by the previously cited cutoff values. If, on the other hand, we observe the risk of bleeding in our analysis, it is obvious that in patients who have low platelet reactivity, they had a significant 1.7-fold higher risk for major bleeding events. Again, p-value extremely significant, confirming that this is not just a simple chanceful finding. This is a really robust result. However, in case of optimal platelet reactivity and high platelet reactivity, there is also a very minor 16% reduction in bleeding events. So this is very plausible that those patients who don't have good platelet inhibition, they have a lower rate for bleeding. But I may turn your attention that the risk of bleeding is dramatically increased in low platelet reactivity, while only slightly decreased in high platelet reactivity compared to this optimal zone. When we wanted to put bleeding and stent thrombosis together, we faced one important issue, and this is absolute frequencies. Because you may know that bleeding is more frequent in general than stent thrombosis. With new generation drug-eluting stents, bleeding in our cohort was 3.4 more frequent than stent thrombosis. So it was 3.8% in our cohort in the bleeding risk, while it was 1.1% the risk of stent thrombosis. So when we wanted to put together bleeding and stent thrombosis, relative risk estimates are not good because they don't reflect this difference in frequencies. So therefore we decided to show the trade-off between bleeding and stent thrombosis with absolute effect measures. And these are the results. I would like to guide you through this quite busy slide. With the gray line, you see the risk of stent thrombosis compared to the reference who have optimal platelet reactivity. And with the red line, you see the absolute risk of bleeding compared, again, to the optimal platelet reactivity zone. And what you see here is that compared to patients who have optimal platelet reactivity, those who have high platelet reactivity can expect a 1.2% absolute risk increase in the risk of stent thrombosis, with a slightly lower 0.6% decrease in major bleeding. In contrast, those patients who have low platelet reactivity, they may expect a significantly higher 2.6% absolute increase in bleeding without any additional benefit in stent thrombosis. So this graph is really similar to what we see with vitamin K antagonist, confirming that there may be a therapeutic window where the absolute risk of bleeding and stent thrombosis is the lowest. So, as I told you, we had quite a heterogeneous population. So we did some interaction analysis to look at whether we had some confounders in which these associations are incorrect. And in general, for bleeding and stent thrombosis, there were no directionally different subgroups. In fact, for bleeding, we had some subgroups where these associations were even stronger. So while in the exploratory studies, bleeding was a predictor, low platelet reactivity was a predictor of bleeding, but in the validation studies, it was even stronger. And although we generated our LPR cutoffs based on the ADAPT-DES, other studies, if we exclude ADAPT-DES, even showed a stronger association for bleeding. And although we had some patients on prasugrel, these associations that we saw for bleeding seemed true for prasugrel as well. Interestingly, we didn't find any association or interaction for ACS or no ACS in terms of the predictive value of low platelet reactivity for bleeding. In case of stent thrombosis, there were no significant interactions regarding exploratory or validation studies, including or excluding the ADAPT-DES study. And in case of clopidogrel or prasugrel treated patients. So these are the overall results from the 17 studies of the over 20,000 patients. And I wanted to show you some dedicated VerifyNow specific results from our analysis that was even not published in this European Heart Journal paper. I told you that VerifyNow consisted the largest cohort in our analysis, including 13,000 patients from 8 studies, and all these gave 64% of the power of the overall analysis. So VerifyNow group is really driving the results. So when we only depict VerifyNow results, the results are really the same. So if you go above 208, you can expect a higher risk of stent thrombosis, over 2-fold higher risk, without any additional benefit if you go down more than 95 PRU. Regarding bleeding, if you go below 95 PRU, there is a significant 1.6-fold higher risk for major bleeding. However, there is no additional benefit if you go to high platelet reactivity zone. So all these results confirm the overall results what we saw in the large analysis. And I think one of the most important features of the VerifyNow testing is that in 13,000 patients, high platelet reactivity was a largely significant determinant of cardiovascular mortality. And this is really an important thing, I believe, because in these patients, it is really important to know what prognosis of the patient may have for the future. And those patients who have high platelet reactivity, who have a PRU above 208, they have an 80% increase in the relative risk of mortality. However, when you compare low platelet reactivity and optimal platelet reactivity, there is no difference in mortality. So, dear colleagues, the conclusion from all this part is that based on this large data set, we can conclude that high platelet reactivity, which was in case of the VerifyNow 208 PRU, is associated with a more than 2-fold higher risk for developing a definite or probable stent thrombosis, and is associated with an 80% increase in mortality. In turn, low platelet reactivity, which was less than 95 PRU in case of VerifyNow, was associated with a 60% increase in major bleeding. So those patients in which you test and have a result between 95 and 208 PRU may have an absolute 1.2% lower risk for stent thrombosis and an absolute 2.6% lower risk of major bleeding event compared to the two extremities. So now, how can we use this data in our clinical practice? And we have some negative experience from prior studies because we have seen from 2 randomized controlled studies that giving a higher dose of clopidogrel in patients who have high platelet reactivity is not reducing the risk of thrombotic complications compared to conventional treatment. However, this is the reason why current guidelines do not recommend routine platelet function testing. But still, platelet function testing is in the guidelines with a selective recommendation, which means that you may consider platelet function testing in specific high-risk situations and in patients on clopidogrel. And I would like to briefly mention many limitations of the available randomized control studies. First one is the inappropriate cutoff. Both the Gravitas and the Arctic studies used a PRU cutoff for high platelet reactivity of 230 or 235. In our cohort, we have validated the relevance of 208 PRU, so maybe an inappropriate cutoff may have played a role in the negative studies. Second is both of these randomized controlled trials included low-risk patients, and this resulted in a low event rate and lack of power. I give you an example. Gravitas was powered for a 5% event rate in the control group, but ended up with an event rate of 2.3%. So less than half of the event occurred in this low-risk population. And third, none of these trials used routinely the new P2Y12 inhibitors to overcome high platelet reactivity. It was only high-dose clopidogrel and Gravitas, and only 12% Prasugrel use in Arctic study. So this is an example of how important it is to look at a different cutoff value. As I told you, in Gravitas, the PRU to select patients with high platelet reactivity was 230. But when they did a post hoc analysis with a PRU of 208, they found out that those patients who had a PRU below 208 in Gravitas study, they had a significantly lower risk for death, stent thrombosis, or myocardial infarction. So in the multivariate model, platelet reactivity below 208 was an independent predictor of better outcomes. So even from a negative study, it seems that 208 PRU and becoming below 208 PRU is a good prognostic indicator. And about the patient profile. I told you that basically Gravitas and Arctic had a very low-risk patient population, 0% of ST elevation patients, a very low percentage of acute myocardial infarction patients, with an all-cause mortality of 0.8% in Gravitas and 2% in Arctic. This is in contrast to our clinical routine. So, for example, in our Hungarian registry, we enrolled 741 patients to explore the value of platelet function testing. And in everyday clinical practice, we included 84% patients with acute myocardial infarction, 50% STEMI, even patients with shock, ending up with an all-cause mortality at 1 year of 8.2%. So this is reality, and all these prior randomized controlled trials used highly selected patients with low risk. And the result of changing treatment in case of high platelet reactivity is also captured by our Hungarian registry, where we compared high platelet reactivity treated with Prasugrel and high platelet reactivity treated with high-dose clopidogrel. And as you see in this slide, the risk of death, MI, stent thrombosis, or stroke is still extremely high in patients with high platelet reactivity who are treated with high-dose clopidogrel. However, if you switch patients to Prasugrel, you can significantly reduce the risk of thrombotic events. So it's not yet done. I can tell you that there are still ongoing randomized studies, such as the Tropical ACS in the platelet function testing field, to look at the prognostic role of platelet function testing. And I hope all these new randomized controlled trials will bring new evidence to support the role of platelet function testing. So finally, I would like to show you two simple examples to learn more about the clinical role of platelet function testing. And the first question is that you want to predict 30-day bleeding risk in your patient after PCI. Which is the best approach to predict 30-day bleeding? Approach number A is platelet reactivity testing with the VerifyNow based on our new results. Or there are some colleagues who may think that we should use clinical bleeding risk scores and they will be better to predict the risk of bleeding. Or is it beneficial to integrate platelet reactivity markers with clinical risk scores? There is a very recent publication from an Italian group, from Fabio Mangiacapra, in 800 elective patients, who directly address this question: which is better, platelet reactivity, clinical risk score, or the combination of the two? And what they found out is that regardless of the type of bleeding definition, both bleeding risk score, platelet reactivity, and the combination predicted the risk of bleeding. However, the best discriminatory value, the best prediction value, can be achieved with the green line when you predict the clinical score with platelet reactivity. So these data highlight that platelet reactivity values should not be viewed on their own, but they are best when they are integrated in the clinical context of the patient. So if you have a patient who have a PRU value lower than 118 and who have a high bleeding risk score, they had really good prediction for bleeding risk in this cohort. Question number 2. You would like to prevent stent thrombosis in a patient who receives an LED stent. How can you best prevent stent thrombosis? I think many of our colleagues say that you should use IVUS, deploy the stent properly, use non-compliant balloon to post-dilate, and that's it. If you deploy your stent properly, the patient will be fine. Don't test platelet reactivity. Second options, believers in platelet reactivity say that platelet reactivity is more important than the procedural features, so do platelet reactivity with VerifyNow. And option C is, what if we combine them together? And we are very lucky that from the RCTS registry, we had also a subgroup analysis of IVUS patients. And this is not only a small group, because it consisted of a group of over 3,000 patients. And of course, the procedural success is really important to your patients, and you can prevent stent thrombosis if you use IVUS. So you can reduce the risk of stent thrombosis by 50%. But if you put IVUS use and platelet reactivity into a multivariable model, you will see that both are equally important. So deploying your stent properly will protect your patients from stent thrombosis, but also knowing your platelet reactivity also is an independent predictor of stent thrombosis. So I believe this is another example showing that clinical variables, procedural results, and platelet reactivity together can make a good and informed decision for the patient. So to conclude, ladies and gentlemen, our collaborative analysis of the largest ever pooled data set of over 20,000 patients clearly showed that HPR is a significant predictor of stent thrombosis and mortality. Low platelet reactivity is a significant predictor of bleeding. And in this data set, VerifyNow contributed to 64% of the overall results. So VerifyNow is really the largest data set in this analysis. And from this VerifyNow specific data set, we can assume that patients above 208 PRU may have 2.2-fold increase for stent thrombosis and an 80% relative increase in mortality. And those below 95 PRU may have a 1.6-fold high risk for major bleeding. Although randomized controlled trials failed to show any benefit favoring platelet function guided treatment, I have mentioned several limitations that should be acknowledged. So I think it's fair to say that although the concept is not yet proved, it has never been disproved. So we believe that new data may still come to fine-tune the role of platelet function testing after PCI. Based on our results, it may seem relevant that platelet reactivity with an optimal zone, so-called therapeutic window, may be relevant to reduce the risk of bleeding and thrombosis, and further randomized controlled trials are needed to define a potential adjustment of treatment to this optimal platelet reactivity zone. Thank you really much for your kind attention.
Well, thank you, Dr. Aradi, for a very, very informative presentation, webinar. It clearly very pertinent and relevant information presented today. We will now enter the question and answer section of today's webinar. As all are muted, please submit questions via the webinar control panel. I will also note, given that we have less than 10 minutes left in today's scheduled webinar session, there may be some follow-up that we will do with regards to some of the questions. So let me begin with, we do have questions that have already come in. The first question that was asked was, how much does non-compliance contribute to the HPR or LPR, and would it be important to test for compliance?
Thank you, Adam. This is a really good question. We all know that our patient's compliance is not so good regarding treatments after PCI or acute coronary syndrome, and with even minor bleeding events influencing compliance, we can expect that many patients stop treatment before an optimal range of length of duration of treatment. And in case of high platelet reactivity, it has been shown that some of the patients who have, with the test results, high platelet reactivity simply didn't take the drug. So non-compliance may play a role in high platelet reactivity by falsifying the results, and it doesn't play any role in the low platelet reactivity because I don't believe the patients are over-treating themselves with the agents. However, I believe the proportion of patients who are non-compliant were not that high in this large data set to interfere with our results. So I think we should start to strengthen the compliance, but the results are valid with these assumptions as well.
Thank you. The next question that has just come in is, how important is the standardization of the platelet function analyzer and why?
Thank you for this question. I believe this is really a very important topic. And we had strong discussions regarding LTA because many centers are using LTA, which in one center is really a useful tool because you have your own cutoff values, you are using the same speed for centrifuging, you are using the same agonist concentrations, but we have to have a completely standardized environment to have cutoff values that we can propose universally. So this is the reason why we agreed that we only include platelet function assays that has a fairly standardized processing method. And for this purpose, we have selected the 3 best standardized assays with which we believe we can recommend very sharp cutoff values for clinical purpose. I believe these sharp cutoff values are only valid if the platelet function testing can be repeated in every different regions of the world, regardless of methodological issues.
Thank you. The next question is there any benefit to doing genetic testing, such as CYP2C19, before stent placement? If so, can you elaborate when it should be done?
Thank you again for this question. I believe genetic testing may have additive information, and it has some benefits compared to platelet function testing. such as you don't have to put your patients on the treatment to know how the patient will or may respond to the drug. So potentially in a patient who is not on the drug, but you would like to know how to treat in a later time, genetic testing can give you a hint. However, genetic plays and explains only a fraction of the things that influence platelet reactivity. So I don't believe genetics alone may be enough to exclude or to separate those patients who have higher risk for stent thrombosis and mortality. So therefore, I would recommend to combine these two if you can, because other factors other than genetic factors such as diabetes, such as acute coronary syndrome inflammation, may also influence platelet reactivity that won't come out in the genetic testing.
Thank you. All right, next question is, why in ADAPT-DES study and also the other studies, the prevalence of non-responders are high, but the ST events are very low?
Yeah, this is really a good question. And I would like to start to explain that even in patients who are not treated by P2Y12 inhibitor, the risk of stent thrombosis is not 100%. That's the reason why high platelet reactivity cannot predict 100% of stent thrombosis events, because stent thrombosis is multifactorial and in general really low. So now with the new generation DES, stent thrombosis is approximately 0.5 to 2%. So in many cases of patients who have high platelet reactivity, they won't suffer stent thrombosis. However, stent thrombosis is still a catastrophic event, and we would like to prevent all these very few events as well. And if you want to prevent these few events, you should look at these potential predictors, how to handle and how to prevent. And as I told you from the other DES, it's very important to make a good stent placement, good apposition. However, it's also important to have a good drug effect. It's not 100% sure to predict stent thrombosis by any of these markers, but these are now our best correlates of these events.
Okay. Well, unfortunately, we have run out of time today. But again, thank you to Dr. Aradi, and thank you all very much for joining us on today's webinar. Thank you. Bye-bye.
Thank you so much for the opportunity. Goodbye.
Thank you, Dr. Aradi.